Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Altered mental status is not a complaint. It is a warning. A signal that the brain, the organ that defines who a person is struggling to function. Sometimes the cause is simple. Sometimes it is reversible. And sometimes it is the first visible sign of catastrophic physiology unfolding just beneath the surface. Today's episode is a scenario, but not a straightforward one. Because that wouldn't be fun. Because in emergency medicine, the moment you feel certain is often the moment you should become more suspicious.
So we're going to run this call in real time.
And you at home should be thinking it through with us.
There will be decision pauses, moments where we want to stop and ask, what would I do next? Scenario phase 1, the dispatch.
Medic 2, Engine 5, respond priority 2. Male subject acting confused. Caller reports possible intoxication. Unknown medical history.
Medic 2 responding.
Engine 5 responding.
Already framing bias.
Right. Dispatch language shapes provider mindset.
I've definitely fallen into some dispatch traps, that's for sure.
Mm-hmm.
So here's a listener pause. Decision point 1. What are your top 5 causes of altered mental status before you even arrive?
Oh man, I was about to say AEIOU tips.
Yeah,
Yes.
Do you guys want to talk about it?
AEIOU
Oh,
tips.
Oh my god.
So AEIOU tips, TIPS, is a pretty classic EMS mnemonic for the differentials on your altered mental status. A is alcohol, whether it's intoxication or withdrawal. You can also have co-ingestion. E is epilepsy or electrolytes, so post-ictal state, post-seizure, or electrolyte abnormalities. I is insulin, hypo or hyperglycemia. Overdose, whether that is drug overdose, or they also put overdose or oxygen, so hypoxia can be in here as well.
Mm-hmm.
And when you think altered mental status, your first thought should always be hypoxia.
Absolutely.
Until proven otherwise.
Yes. U is uremia, so kidney failure, a buildup of toxins. T, trauma and temperature. I, your second I, is infection, sepsis, meningitis, encephalitis. P is poisoning or psychiatric, so either a toxin exposure or a psychiatric cause.
So a lot of things to be thinking about,
Yeah.
for sure.
The last one is S, stroke or shock. So basically,
Anything.
all of it.
All of it.
And I guarantee you, you're probably not going through AEIOU tips on the way to this call. You are thinking,
Man, this drunk guy.
caller reports possible intoxication.
All right, let's get back to our scenario. We're going to talk about how you enter the scene next. It's an apartment building. You're on the 3rd floor. It's warm, and there's a faint smell of cigarette smoke.
Of course.
The door is open. The TV is at a high volume.
It always is.
And the patient is seated on the couch. You see a 52-year-old male, disheveled, diaphoretic, with glassy eyes. The patient is mumbling, "I don't need any help."
They always are.
They always are.
But you are very vigilant, and you get a set of vitals.
After he says pan.
Yes, after
If
you
want
get
to,
consent.
darling.
Your vitals are as follows. You have a heart rate of 108. You have a blood pressure of 152/90. Your respiratory rate, because you did count it, is 22. And your SpO2 is 97 with a blood sugar of 112. You do find some beer cans present on the scene.
Are you trying to confuse us?
Right. So these
Yes.
vital signs. I mean, this whole scene screams intoxication.
Yeah, it does. That's what I would think right off the
Mhm.
bat here.
Which is exactly why it's dangerous.
All right, decision point 2. What assessments must be done before we label this intoxication? We've gotten vitals.
Yep.
We have got our blood sugar, which was 112. He's sounding fine, right? Is he? Yep. 97%. What else should we do?
I want to do a neuro exam.
Okay.
Beautiful.
I'm definitely just going to make sure we do like a head to toe if he allows us to. Make sure there's no
Yeah,
injuries to his head or anything like that we find.
for sure. Like check pupils.
Yeah.
Make sure we've got, we're equal and reactive. We're not pinpoint.
If
all of
he
that.
is simultaneously intoxicated and is experiencing some kind of injury or illness, it may be difficult to do something like a stroke assessment.
Absolutely, because it depends on how well we can follow commands.
Yeah.
True.
Yep. But then also, how well can you roll that out? Man, intoxication really just
It's tricky.
Sketchy.
throws a wrench in everything.
It
You gotta
is
be
sketchy.
careful. But they did say something. Diaphoretic?
Yeah, the diaphoresis is what's strange to me.
Yeah.
Because drunk people aren't often very sweaty
They're
unless they've
usually-
been doing some weird drunken behavior.
Yeah. And I mean, usually they're probably dehydrated.
Yeah. Normally you don't find a drunk person on their couch just really sweaty unless they're like, I've been throwing up.
Yeah.
But the diaphoresis is odd.
It is odd. It's something to think about for sure.
Yep. It
Mhm.
should be a little red flag.
Yeah. Aubrey has a rule that if you're sweaty,
You cannot refuse.
you're going.
You're going to the hospital.
You're
Why are you
going.
sweaty?
There's something wrong.
I'm not
Something
sure
bad
this man
wrong.
can refuse either. Is he alert and oriented? Is he
Right.
able to answer those questions?
That's another good assessment to do.
Yeah.
Assess his
His
decision-making capacity.
assess his ability to be safe at home,
Yep.
if we do leave him.
Well, that's phase 3.
Yeah.
So our first change.
Uh-oh.
Patient suddenly becomes agitated, stands, nearly falls, right arm drifts, speech slurs further, now we are vomiting.
Okay. Did this man hit his noggin? We need to see if he has any medicines or something. I don't know.
Dispatch, upgrade to priority 1, possible stroke symptoms.
Priority 1 acknowledged.
Where's that?
Some people do that. So we talked to Ashley and they said that they do that. So they will update dispatch
Oh.
that their scene is either what it seemed like or they're
Or it is
sicker.
something else. Oh, okay, cool. So now that we've told dispatch about it, we are shifting gears.
Now we have a stroke alert mindset.
But stay open because altered mental status can stack diagnoses, which
Mhm.
is why we're here today. So our new clues, right? While we're packaging the patient, this is what I was talking about earlier, we
Mhm.
find some things available to us on the
Oh,
kitchen
no.
counter. There are insulin vials, syringes, pill bottles, and an unopened eviction notice. How did they know it was an eviction notice?
Did we open their mail?
Okay, I'm just going to say,
Don't open
And-
their mail.
and an eviction notice. This man is going through it.
Uh-oh.
But the neighbor arrives.
Oh, the neighbor.
He's a diabetic and he hasn't eaten. He's been He's been repressed.
He's been repressed for years.
He's diabetic.
Hey, diabetic.
He
I mean,
diabetic.
you can say it wrong. It's the neighbor.
That is true. He's diabetic and he hasn't eaten and he's been depressed.
Oh my gosh. Well, after all of this,
Why don't we repeat the glucose? Fire got it before we got there. Let's just make sure.
We all know that they don't calibrate a glucometer.
They don't usually calibrate there. So ours was calibrated this morning.
Yeah, so
Oh,
let's check it
good.
again.
Yeah, James, do you want to get another glucose?
I would love to.
All right. Thank you.
It's 58.
Okay.
Well, this has been a roller coaster, but also could explain everything.
Decision point 3, I suppose. Treat and reassess. Or continue stroke pathway.
Well, I have been told never to call a stroke alert with a hypoglycemic patient.
Facts.
Yep.
So,
I do not like that.
so do we think that either our first glucose was incorrect, or since he's a diabetic, maybe he took a whole lot of insulin and we caught it on the downslope?
Should we double check just to make sure since we have two competing numbers?
I would love
I think that's
to.
a great idea.
Okay. I'll check. Uh-oh. 42.
Okay.
So we caught it on the downstroke. So now, I think, personally, if you guys agree, we should treat that
I think so.
prior to calling a stroke alert.
All right.
Yeah, let's put a hold on that for a moment.
Well, I guess we'll get a line and what are we going to give?
All right, so dextrose has been administered. Our patient seems to be improving.
Okay.
He's becoming oriented. And now he's refusing transport.
Sir, we need to know
Fuck.
why your blood sugar was low. You're diabetic.
Yes, so this is a classic temptation to clear. But we have learned some information that means maybe we should do some more investigating.
A little more, right?
If this man is going to make us go through the roller coaster of all of that, we're going to make him go through a roller coaster of refusal.
Absolutely.
Okay?
And everything that we found on his table means that this may not be a one-time fixy situation.
Yeah.
Mhm.
So, decision point number 4. Would you allow refusal at this time?
Not at this time. I would like to investigate
Yeah, I think
Yeah.
so.
a bit further.
We need to make sure it stays up, right? Even
Yeah.
I've had some patients who, were reasonable to be left with their, partner or whatever
sure.
it is at home
Absolutely.
after we gave them some D10 and the story all added up and it made sense and we knew exactly what happened and that happens. But here, there's a lot of, again, competing factors.
For sure. And I'm going to stick around and be pesky for long enough to see if this blood sugar comes back down.
Yeah.
So even though he's like, get out of
'Cause he
my...
was just
I'm
normal.
refusing, get out. I'm going to find some ways to be pesky and stick around for a
Yeah,
bit.
yeah. I'm also a little bit concerned that maybe this is intentional.
Yeah.
Some intentional self-harm.
That's what I'm worried about, is that we took a large amount of insulin and this is going to reoccur.
And there's other things, too, that could cause low sugar, right?
Mm-hmm. So during refusal paperwork, you know what? It actually wasn't my call. It was my partner's call. My partner decided to let them sign a refusal.
Oh, man.
I know, crazy. So during refusal paperwork, the patient suddenly develops a severe headache,
What the heck?
photophobia, projectile vomiting, decreased LOC, and pupil asymmetry.
This is a
noted.
roller coaster,
Oh,
Jamie.
sir.
What in the world?
This
You're
man.
going to need to go to the hospital, sir.
Well, good thing. Dispatch priority 1 transport. Neurological
stroke.
deterioration.
Copy priority run.
Code stroke it is, I guess.
I guess so.
So, our blood pressure, it looks like it's rising. Our heart rate's slowing down. Oh, no. Is he breathing?
Yeah, but they're irregular.
Yeah, he just took a deep breath.
Oh.
They're irregular. So what is this respiratory pattern called?
It's called my worst fear. No, I'm just kidding. It is called Shane Stokes. Or Shane, however other people say it.
Cheyenne Stokwa. Shane Stokes.
This is Cushing's.
Yes, it is Cushing's triad, and it is an indicator of possibly increased ICP.
But also, we still have to consider some sort of tox ingestion, some sort of metabolic derangement, which, I do think we also had going on. Sepsis, a history of trauma, that could be the origin of
Right,
maybe
a head
this
injury.
ICP.
All right, decision point number 5. Are we planning an airway strategy right now?
Absolutely.
All right. So, if we're going to plan an airway strategy, let's pause here and say you are... Obviously, we've just chosen to transport by ground, so that means air is unavailable, and we are 30 minutes from our stroke center.
If we are 30 minutes from our stroke center, we clearly have some signs of increased ICP, and we're entering like a Cushing's triad. My biggest concern is that we, at some point in the near future, are going to lose this airway, or at the very least, the ability to control it. So RSI is kind of what I'm planning.
Are we worried about the heart rate?
Slowing, yeah, but
What
It's
do we do?
idiopathic.
Yeah, what do we do? Give him some atropine?
give him some atropine.
Hope for the best?
Yeah.
He definitely... I mean, he was already projectile vomiting, and now he's unable to maintain his airway. I think that...
It kind of pushes you into a corner and puts you
Right.
in a hard spot.
I think it's appropriate.
The thing
Yeah.
about Cushing's is it ain't going to get better. You
Hey,
know
but
what
we
I
don't
mean?
RSI him. Somebody's going to RSI him.
Yeah.
Yeah, and I think that that's a good point, is that like Cushing's is not going to improve itself.
Right.
And so you really just have to jump in there, hopefully on the early end, so that he can have a positive outcome. But losing the airway is not really a great option. You don't want to just kind of, you wouldn't want to wait until he
Right.
completely loses his airway on his own to then go ahead and intubate, because it just increased risks so much. Now, if that's all you've got, that's all you've got.
Yeah.
Some people don't have the protocols to RSI, and so they do have to wait until the patient loses their airway completely. But if that's the case, bag, suction, do the best you can. If you have an option to intervene sooner, I think it's appropriate to do so.
Yeah. So what if we, for some reason, don't have the ability to intubate at all? Say he is, his jaw is clenched. We can't RSI. What should we do?
Throw in an MPA and bag him.
All right. I think so.
Rolling on the side, I guess.
Recovery physician.
Suction. Get the suction out.
Also suction.
Yeah.
Yeah.
Yeah, and at that, you're having a rough day. Use an adjunct the best you can.
Yeah.
Ventilate the best you can. Yeah. You're not working with much.
Give your TXA if you have TXA and it's in your protocols to give it in this scenario.
Mm-hmm.
All right.
How do you lay your patient?
This is a great question. 30 degrees.
30 degrees. So anyone that you are concerned has an increased ICP or potential head bleed or whatever it is that we think is going on, put him at 30 degrees. You don't want to lay him supine because it can increase that ICP.
That's probably good for our airway too. Definitely not flat.
Okay, well, the good news is we got to the hospital.
Thank goodness. That was stressful.
That was
fun.
stressful. We go back a little bit later and kind of get an update on this patient, and we find that they had a large intracranial hemorrhage. So we were eventually correct in our differential diagnosis. However, we do a little bit more digging, and we look into their labs, and it turns out that we were correct the whole time. Anyway, we sliced it or diced it, because this patient was having severe renal dysfunction. They had hypoglycemic reoccurrence, so they actually got hypoglycemic again once they got to the hospital. And they also had alcohol in their system. So this was not one diagnosis. This was 3 overlapping emergencies that we just happened to see all of them.
Yeah, which you can look at half empty, like you were going to be wrong no matter what. Or you can look at half full, like you were going to be right no matter what.
That's right. Yeah, exactly.
You thought he was drunk? Correct. Thought he was hypoglycemic? Correct. Thought he was encephalopathic?
Correct.
Thought he had a brain bleed? Correct.
Correct.
And that is why we're talking about this, because it can be everything and nothing, or the most complicated, simple call ever. And this is loosely based on a real call. Fun fact that yours truly had to run. So this call really demonstrates those cognitive traps, and Jamie and I were discussing this in like a couple episodes ago, where sometimes we just like have this preconceived notion before we get there, like our dispatch, our CAD notes are giving us information, and we just kind of are like, meh, this is gonna be stupid or whatever. It's gonna be silly, and we can fall into those cognitive traps, like you may in this situation, anchoring to that intoxication, the premature closure after glucose correction, or, not like being really thorough and we only grabbed that one glucose after we found the insulin and all that, or failure to recognize that evolving neurological decline.
Yeah, I feel like the
for
key
sure.
to this scenario is assess. Like continue to reassess after every decision point you make,
Yes.
because after every decision point there was a patient condition change, and if you miss those, then you'll find yourself in some hot water.
Yeah. And I will say this 100% of the time, if you have a patient who is presenting with an injury or illness and the decision has been made for whatever reason to allow the patient to refuse, that should be your most complicated run report and your longest scene time.
100%.
Mhm.
I think that it is absurd that people like want to get refusals, because
I don't.
that is my hardest
No.
report to write, because I put in so much detail
Yeah.
basically as to why this patient refused. And when it is like 3 sentences and done, you're doing it wrong.
Yeah.
I would
And
rather transport you, because honestly it's easier.
it's safer for me, that's for sure. It's probably safer
Mhm.
for you.
Yeah.
Mhm.
And, like, truly, and people get mad when I say this. It's okay. most refusals are ALS run tickets.
Yeah.
Yeah.
Most of
Sorry.
Most of them
Agreed.
are.
Did you do every assessment you could in your power to ensure this patient would be safe?
Mm-hmm.
If
It
you
is-
did, it's probably ALS.
Yeah, it is very rare. Like, and when we're saying refusal, we're talking about
Of
like
a sick.
legitimate
patient.
refusals.
Like, they're-
I know that like we write refusals if someone has any complaint at all.
Yeah, we're
So,
talking
like,
about they're
if you
truly
get
sick.
there and their elbow's scraped, that's not what we mean. But
Trauma
yeah,
naked.
you get there and someone's like, I'm having chest pain, but I just wanted to see if I was
Right.
dying or not. And you're like, oh my goodness.
Don't give that to your EMT.
Yeah, don't let your
You
EMT
weirdo.
write that. Seizures are huge ones that
Yeah.
I see a lot of EMTs will write
Yeah.
a seizure refusal
Just because they have a history.
yeah, they have a history. They had a witness seizure. They were post-ictal when you first got there. They had a return to their mental status baseline, and then they were able to refuse and had the cognitive ability to do so. And then the EMT writes it, and I'm like, they wouldn't have ridden with it.
Yeah,
They
if you would
shouldn't
not
write
ride with it, you should not ride it.
Mhm.
Yeah.
Yeah. I always think that's wild. But some clinical realities. So,
Oh, let's talk about so we said this in the beginning. Altered mental status is not the problem. Just remember that. It is not it may be your chief complaint, but it is not necessarily your primary impression.
yes,
If
there
you
is
will.
an etiology that has
Right.
caused the altered mental status.
You don't just become altered in the end. So, metabolic causes, which we discussed, neurologic catastrophe, like severe neurological injury.
Mhm.
Psychiatric issues, toxicological exposure, or like medication ingestion, or drug ingestion, maybe alcohol, and then also like just systemic illness. Like, it could literally be a urinary tract infection, or it could be something as sinister as, wow, my brain's not working. Meningitis,
Yeah.
right?
Well, and like, oh my gosh, a UTI. These mamas out here,
Oh yeah. So I mean,
they
a
will get a
million
UTI
things.
and just be wild.
Right. Exactly.
Wild.
They're like, I don't know what's wrong with Granny. And I'm like, oh, she doesn't drink water, does she?
Yeah.
I
She's
know-
been wet in the bed, huh?
Yeah. I also think that it is important to point out that just because you go with one pathway on a call, you can always change your mind and go down another pathway. I think sometimes we get stuck on like, well, this is what I first started treating, so like I have to stick with it, because if I change my pathway, that means I was wrong. And like,
Yes.
that's not
fine.
what's best for the patient. You are always getting more information. You're always collecting more data. You are always, more things are brought to light. So you are allowed to change your mind.
The
And that is
bravest thing.
okay.
Yeah.
The bravest thing you'll ever do is change your mind.
Oh.
So tonight's patient looked intoxicated. And he was. But he was also hypoglycemic. And he was also bleeding into his brain. And he was also deteriorating metabolically. Emergency medicine is not about finding one answer. It is about staying curious long enough to find the truth. Because altered mental status is rarely the whole story.
If this episode brought you value, take a moment to rate and review the show. It helps more providers find us. Follow Life in Sirens, join our mailing list for exclusive content, and visit lifeinsirenspodcast.com for resources and downloadables built for the modern provider. And if this conversation made you think, send it to your partner, your preceptee, or someone on your crew, because better providers build better systems.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.